In this video, we demonstrate proper technique of removing a white cataract caused by chronic uveitis in a sarcoidosis patient. After creating our clear corneal incision, we use a blade to gently remove and dissect posterior synechiae. This is aided by the use of viscoelastic for viscodissection. Next, we use a Malyugin ring to help dilate our constricted pupil. Although this seems challenging, the Malyugin ring is very gentle and flexible, and with the aid of a second instrument, we're able to successfully employ all of the scrolls against the iris and help dilate it to an adequate size. Next, we remove some of the viscoelastic material from the anterior chamber, and we use Trifan blue to stain the anterior lens capsule for better visualization. We then reinflate the anterior chamber with more viscoelastic and use a cystotome to begin our capsulorhexis. Because the capsule is often fibrotic with these white cataracts in patients with uveitis, we sometimes have to go back to using the cystotome along with the utrato forceps to help continue and complete the capsulorhexis. Sometimes you may have to change directions, and you may have to employ the can opener technique. The key is to be patient and continue filling the anterior chamber with viscoelastic as needed. Once we're successfully able to complete the capsulorhexis, we use BSS for gentle hydrodissection and hydrodelineation. With a white cataract, we don't often see a red reflex. We use phacoemulsification to create a central groove, and then we employ the technique of phaco-chop to remove all of the nuclear material. Once this is accomplished, we move on to the irrigation aspiration unit to remove any remaining cortical debris. We re-inject the viscoelastic to fill the capsular bag. Our lens of choice is the Johnson & Johnson Vision ZC-BOO one-piece acrylic lens. This lens offers superior optics and unfolds very easily inside of the capsular bag. We then gently remove the Malyugin ring. Because the ring is so gentle on the eye, there's no bleeding noted from the iris, and the pupil is still relatively round without significant correctopia. We use the irrigation aspiration to remove any remaining viscoelastic material, and then we hydrate our incisions.